Good evening all, welcome to tonight's APHN webinar. Tonight's topic is influenza and pneumococcal disease and vaccine recommendations. We are pleased to welcome our presenters for tonight, Dr. John Litt and Angela Newbound. This webinar is live and interactive, and you're encouraged to participate by posting questions to the presenters. Those questions can be typed in the chat box on the bottom left-hand corner of your screen. All questions will be answered during the presentation. And if you experience audio difficulty during the webinar, please don't hesitate to call the Redback support team in the number provided. I'll now hand over to...
Thanks, Alex, and good evening, everybody. Just before we start, both my presentation and Angela's will be available on the website. There are a few technical steps it'll have to go through before that happens, so it should be up in the next 1 to 2 weeks. My talk, I have actually got a number of slides from some medical colleagues, and one of the conditions to get access to them was that people can have a look at the presentations, but they can't print them out or pass them on. Angela's presentation will be freely downloadable and you can exchange it, but both will be available. So on the first slide here, I'm just declaring my various memberships and conflicts of interest. I have been a member of the Immunisation Coalition Scientific Advisory Board. That was known as the ISG in its previous life, and I've been on that for about 8 years. And similarly, I'm on the National Centre for Immunisation Research and Surveillance Scientific Advisory Committee. I do receive honoraria from Seqirus on 2 of their vaccine advisory groups, one for Zoster, one for pneumococcal. The slides that I'm presenting are either mine or my colleagues and represent my work. There are no industry or pharmaceutical slides provided for this discussion. So moving on to the next slide, it's going to be in 2 parts. I'm going to cover largely adult and older persons vaccine preventable diseases, and we'll start with influenza, and that will mirror very much, it'll be mirrored by the pneumococcal story later. So both will look at the burden of illness and the epidemiology and who's at particular risk and why, a little bit about the pathophysiology, and then really to focus on prevention, which is largely going to look at vaccination. Antivirals can be used for influenza, and I'm happy to take questions on those, but that's not the main focus of the talk because it's not the main prevention strategy. There are a number of issues related to both vaccines, and I'm going to cover those in a little bit of detail because I think that will provide you with some background, particularly when you're talking to your patients and folk asking about these vaccines to sort of answer clinical questions and queries that they might have. So if we look at the next slide, we're actually quite lucky that in the last 10 years we've now got a lot more information around both surveillance and monitoring of influenza, and the pandemic in 2009 made a big difference to that. And so at the GP level we have a lot of sentinel practices. So one of them is based here in South Australia in the University of Adelaide General Practice Department with Nigel Stocks, and that has GPs recording influenza-like illnesses throughout the year and doing some swabs to determine what the particular virus is circulating. And that's very much complemented by other data sets including FluCan, which is a data set largely focusing on people attending hospital and being admitted to ICU or other wards, and again doing a similar sort of thing, looking about who's got influenza, what actually happens to them and what's the outcome for that. And so with all of the vaccines on the National Immunisation schedule, a requirement is to do surveillance, and it hasn't been as good with influenza and pneumococcal, but it's certainly been boosted by these strategies and the pandemic in 2019. So looking at the next slide of the burden of illness, we can actually see that influenza is the #1 notifiable vaccine preventable disease by a long shot. And so it dwarfs most of the childhood vaccinations. I mean, ironically, part of that is because we've actually had such good programs with measles and Hep B and Haemophilus and Meng C that we've largely got rid of those diseases because of the vaccination. But looking at both influenza and pneumococcal, we've got a long way to go to actually reduce the burden of disease, and there are a number of reasons for that which I'll be touching on in both diseases this evening. The other thing coming from the slide is that we typically expect an attack rate of about 5% per year. That'll be a lot higher in children. It could actually be up to 25% as it was in the 2009 pandemic. And so it means that 1 in 12 people, so 1 in 10, 12 people in a typical season is actually going to have influenza. It's also worth noting that there are a number of people that are asymptomatic, and I'll talk a bit more about that, which actually does depart from our usual understanding of what influenza looks like, but I'll comment more on that a bit later. So if we start to put the numbers from those data sets into the various areas, and this is a composite, if you like, over the last few years, it's not representing any one particular season. Typically, we're going to have somewhere between 2,500 and 3,500 deaths. To give you a comparison, before we started a lot of the public health interventions for the road toll, we had a road toll of equivalent of about 3,500 per year, and we've now had a big impact on that. Now, when you look at the death certificates in hospital, the numbers are actually much smaller for influenza, but it is very much under-recorded and not front of mind when the certificates are filled out. And most of the evidence would suggest that there's a kind of tenfold difference. So the numbers I've got here are the actual numbers, but when you hear people say kind of in official reports that we've only had about 500 or 600 deaths in a year, they haven't taken into account that multiplier effect. You can see that the hospital admissions are substantive, and so typically you're going to get around 25,000 or so, plus or minus, in a year. And for a typical general practice, you're going to expect to see per GP somewhere between 10 and 15 extra patient consultations in a GP consulting week when there's influenza about. And so that kind of translates into something like 500,000 cases a year. So that's a significant burden of illness. So typically when we've seen influenza, it's 1 minute you're well and the next minute you feel severely, significantly unwell. You've got a high fever, a cough, a sore throat, and aching all over. And people would sort of describe it like being hit by a truck. After the pandemic in 2009, it became apparent that sometimes influenza doesn't appear, as such a distinct syndrome from other like cold-like or cold and flu things circulating, like coronavirus or adenovirus and the like. And so we used to be able to say to people, well, flu is different, but it is a little bit harder to do that. But this is still a fairly typical presentation. The other complications of influenza to keep in mind are pneumonia in the first instance, and that can be both viral and bacterial, and commonly it's pneumococcal pneumonia. And it also leads to a worsening of clinical disease. As I'll describe later, it's a bit like a patient running a marathon. If you haven't trained for a marathon and then on Saturday you had to run it, just imagine how you'd feel at the end of it. Well, that's exactly the impact that influenza has on people who've got a range of risk factors like diabetes, chronic kidney disease, heart and lung problems, or a range of degenerative neuromuscular conditions, and also people that are significantly overweight or pregnant. The other problems it causes, particularly in children, is bronchiolitis, which is different from pneumonia, but often leads to a lot of kids presenting to hospital. And about 1 in 3 children who have a bout of influenza are going to get otitis media. Ray's syndrome is a very uncommon neurological problem, and it's quite serious and significant, but it largely is occurring in kids that are taking aspirin, and most people are aware that we're not generally using aspirin as an antipyretic for children, so we don't see much of Ray's syndrome currently. This is a complicated slide, so it comes from those data sets that I talked about. So if you look at the first one, and I hope you can see the mouse the cursor there, there's a red curve there which follows the 12 months of the year, and you can see that it's peaking around August and into early September. That's the current, or last year's 2016 season. It was a fairly moderate season, and it wasn't quite as heavy as both the 2012 and the 2014, which are represented by the other two dashed lines and a slightly taller peak. If we move across to the graph with all the yellow in it, that's actually telling us which particular viruses were a problem and at what time of the year. And so the green in that is the influenza B, and that was happening earlier in the season, and the yellow is the H3. So you'll remember that there are two A strains. There's an H1N1 and there's an H3N2, which have been largely circulating. And when we put the vaccine together, we make sure that we've got a strain against both the H3 and against the H1. And so most of the H3 disease occurred more toward the end of winter and into early spring. And then if you look at the FluCan data, and this is data that's largely focused on hospital settings there, the pattern is slightly different. And so you can see that, it's a bit hard to read the little coloured bars there, but you can see that 3/4 of the population who ended up in hospital have some other chronic illness, and the number of influenza B cases was about 7% or so. The mortality in this group, and this is of people who attended the hospital, was about 3.4%. If you look at the mortality in the wider population of all people that get flu, it's probably somewhere between about 1 in 2,000 people or so. So this is a more selected population of people that are ill and presenting to hospital. So moving to the next slide, this gives you an idea about the sort of pattern of influenza that laboratories see. So if you front up to your general practitioner and you've got an influenza-like illness and they're part of the monitoring system, or they believe that they need to screen you for seeing whether you've got flu, in a young child they'll take a deep, or adult they'll take a deep nasal swab, or ideally if they've got facilities to do a nasopharyngeal aspirate on the child and send it off to the lab, who now provide us with a panel of a range of common respiratory viruses and tell us whether it's flu or paraflu or something else at the time, which has been really useful. And that's largely been ramped up quite significantly since 2009, when the laboratories were required to do that, when we had the pandemic and they were really trying to work out where the cases were and what we needed to do. Now, one of the skewing factors of this is that this doesn't necessarily tell you the actual numbers of people that have got flu. It's the people who have actually got swabbed and went off to a clinician or to a hospital emergency department. And so it is skewed towards children. So even though we know that in really young children it's got a very high incidence, we also know that it's very high in adults and, in older people. And that's really not as typically shown by this graph. The over 65s are much less than children, when in fact the actual incidence in that group of people over 65 is much higher. And it's really largely saying that we're not screening that group of people quite as often as we are in young children. So if we actually now look at a subgroup who are at higher risk, and that's the Aboriginal population, this is showing you the age distribution from really young children up to the age of 6 months through to the elderly, and the dark red bars are the Indigenous population. And so you can see from the figure there, in children under the age of 6 months, an Aboriginal child is 6 times more likely to have influenza notified than a Caucasian or other child. And in the adult population, or the elderly population at the other end of the curve, you can see in the over 65s, they're 3 times more likely. And so because they're a risk group and because they often live in conditions that are conducive to rapidly spreading influenza, it's not surprising that they're monitored a bit, but their incidence generally is higher. So it's not just a matter of actually doing the screening. If we look at the next slide, this is around deaths. And so the most notable thing from this slide is you can see in the over 65s that the highest number of deaths is in that group, and probably 90% of the deaths from influenza occur in the older population. Now, there are 3 bars there. The first dark green bar is before the pandemic, and you can see that the hatch bar, which is the 2009 year, the deaths went up in the pandemic because a lot more people had flu. We know from the serology around that time that 1 in 4 of the Australian population have had pandemic influenza, and that kind of mortality has remained high in the groups since 2009, and I'll talk a bit more about some of the reasons for that, because it's partly related to the strain of influenza and the age group. So moving on to the next slide, this is just really amplifying that it's not just the elderly, but the people over the age of 75. Most of you would be probably involved in 75 plus health assessments, which we've had for the last 18 years. And part of the reason to introduce it at the age of 75 was that morbidity and and collecting diseases rises quite substantively after that age, and it's not just a small subgroup, but a lot more people. And that is reflected in the mortality of that, is that the more diseases you accumulate, it feels like the more marathons you're going to run, and it's quite that the mortality actually is higher in that group. So looking at the next, so this is the mortality rate in Aboriginal populations, and again it mirrors the incidence, so it's actually highest in the over 65s, and that's about 3 times higher than those who are in the Caucasian population. And it is also slightly higher in the really young children under the age of 6 months. The bars there are the error bars, so they're, because the numbers are really small, it means that the estimates we've got are fairly rubbery, and if we did repeated numbers of that, then that's why there's some variation within that. I'll talk a bit more about the error bars when we come to some of the other graphs there. So summarising the hospital sort of situation for 2015, because that's the most recent available, they had 2,070 deaths in that period of time, and the mortality that year was about 2%. It's 50% higher. It's 3.3% in the over 65s, and about 1 in 12 people who went to hospital ended up in ICU. So when they actually have a look at that group and they worked out under the National Immunisation Program, who's eligible for the vaccine, how effective was it? And with the swabs they're using in the PCR testing, we can now get some estimates of the effectiveness. And so the vaccine effectiveness in a higher risk group that are being hospitalised was around 45%. So typically we think that flu in an adult population will give you about 50% protection about getting a case of flu, but it tends to be in a healthy population a high level of protection about ending up in hospital. But if you've got other risk factors, or you've got other serious underlying illness there, then the vaccine effectiveness is not going to be quite as good. And a lot of people might comment to say, well, look, if this was measles or meningitis, it'd be unacceptable. And it's one of the challenges we face with adult vaccines, is that we don't have vaccines that have kind of 90% effectiveness like we're used to with children. And it's an area that we actually need to try and lift our game as much as possible. The final dot point on the slide is actually just also highlighting that through the program we actually averted quite a few admissions to hospital, and that's useful to know because health ministers spend a lot of money on the immunisation programs, and they want to know that it's actually making a difference. And so effectively what that says is if we didn't offer flu vaccine to the people in those age groups and they didn't get it, then we'd probably have twice as number of people ending up in hospital. And as I've mentioned before, we've got something like 25,000 hospitalisations in a really bad season. So that's quite a lot, and we certainly see that in the winter period. Okay, so most of you will be aware that we've now switched to including 2 B viruses in the flu vaccine. So we've actually got both B Victoria and B Yamagata, and there are different strains. And that started last year, and this year we've only got the 4 strains within the vaccine. So we've got 2 A strains, an H1 and an H3 strain, and we've got 2 B strains. And part of the reasoning behind that was that in the last sort of 10 or 15 years, we've not matched the circulating B strain very well. The committee that decides on the strains in the flu vaccine meet in kind of October and have a look at the epidemiology around Australia, Southeast Asia, and in Europe, and then make a decision about which strains they'll tell the manufacturers to include in the vaccines. And because we've not matched the B strains particularly well, it's been a decision's been made, and it's happened in other countries as well, is to actually have both lineages in there. And my estimate would be you'd probably get about a 5 to 10% additional benefit by doing that, because B certainly seems to affect children, and depending on the season, it could be anywhere between 10 and 20% of the circulating virus. In the last few years, it's been more often the H1 and H3 strains, but it's not insignificant for that. So that's part of the reason why we've got a quadrivalent flu vaccine with both 2As and 2Bs. So looking at the next slide there, this kind of cartoon highlights that we actually do need to take it seriously. So I mentioned from the pandemic that the 2009 strain it really didn't look that different from someone with an influenza-like illness. And in fact, in one of the Aboriginal outstations where they had an Aboriginal chap that died very early on in the 2009 pandemic, and they swabbed the whole community, and this is a community of less than 50 people, something like about 80% of people had antibodies to the pandemic flu, and none of them had symptoms. And so what it means is you don't feel that unwell. You often go out, if you've had a cold or a bit of a runny nose, you think, well, I'm going out to see friends, or I'm going out to do some shopping or whatever, it's not a problem. But it is possible if influenza's around that could actually be flu. And so while the classic case of the severe aches and pains, sore throat, high temperature, looking unwell is distinguished and you're not well enough to go out, it is possible that you could go out with flu, and more problematically you could end up going to work and spread it to your colleagues. And I'll show a slide later of a French study that showed the multiplier effect if you've got clinicians and staff with influenza as well as patients. It really is a diabolical mix for those in a very vulnerable situation. So while we say it seems to be trivialised for that, anybody's got an influenza-like illness, if we think influenza is circulating, then the odds are that probably 50-60% of those, once the sentinel practices are reporting that they're actually finding flu when the labs get back to us, is that that person should probably not be going out because they could actually have influenza, and then that could be quite significant. So if we look about what does it do to the system, and having mentioned about a third of the cases are asymptomatic, that makes it much harder. Now, in some people it doesn't seem to be as serious, but the kind of marathon analogy is really important. And the things that make it more likely it's going to be severe is your age, because your immune system tends to decline with the years. The strength of your response and the various frontline agents that protect the body from attack or invasion just don't seem to work as well. For a range of reasons, and I'll elaborate more on these in the next few slides, underlying chronic disease also increases your risk of the complications of influenza if you get it, which is why they're in the risk groups that we say we need to sort of offer them the vaccine. For similar reasons, people who are specifically immunocompromised because of a range of diseases like HIV or blood cell cancers or solid tumours or organ transplants or stem cell transplants, their immune system is not working as well and they're much more vulnerable to getting a much more severe episode. The final factor is they're not all the same. You would have heard a lot of stuff out of China and other places where we've got H5 and H7 and H9 strains, and in some of those the mortality is around 30 to 40%. And so that the virulence of the strains do vary, and that's why it's very important that the WHO Collaborating Centre for Influenza monitors that process to keep an eye on what is circulating and give advice. And that's why in those sort of countries often they do a chicken cull, because the chickens are frequently a reservoir for the virus and are trying to minimise the spread to the human population. It also depends on what you've had before. And so there's a term called original antigenic sin. And so whatever your first severe bout of influenza, whether it's an H1 or H3, that seems to be the kind of best protection you've got. And so when we look at the 2009 pandemic, most of the deaths were in people that were actually under 65, because those in that population who are older, my age and older, they've actually had exposure to H1, but that pattern changed a number of years ago, and so a lot of younger people now have had H3 exposure and have had very little exposure to the H1 virus. And so when the pandemic came around, it was really quite problematic, and for those who hadn't had previous exposure, they were quite significantly affected. So moving to the next slide, the main effect is on the lung, and most of your defence in the lung, other than antibodies, is there's some surface effects in the mucus that covers the bronchi and the trachea, and the various macrophages that sit within that. And so what happens when the influenza arrives in the lungs, at the top end of the lung, it has a key-like mechanism through a sialic acid receptor to try and break into the cell, and that whole process, the airways start to react. So macrophages sort of migrate to the area and engulf the virus, and as part of that process release a range of chemicals that have quite a significant impact on the body and actually cause part of the symptoms associated with flu. And so cytokines and interferons are two of those that we know well. For those of you in practice that are treating people with treating people with hepatitis B, it's common practice as part of the treatment protocol to give people interferon once a week. And the patients, if you ask them, will tell you they feel like they've had a bout of flu. If the injection's given on a Friday, they have the flu over the weekend, they just get better, and then the whole process starts again. And so the kind of reaction the body has is partly influenced by the virus, but also by the body's reaction to that. And so a whole lot of things happen. The cells get fairly leaky. You get a triggering of wheezing and an outpouring of mucus and a fair bit of irritation. And so all of that relates to the kind of various symptoms that we see. Now, the more nasty flu viruses, so the H5, H7, H9s, which we are not seeing in Australia, but always worried that we've got to keep a lookout for them, they have a different sort of sialic acid key. If you like, they've kind of got the backdoor key. So we pay most attention to keeping things out through the front door, which is in the top end of your airways, through the throat and things, because that's the first port of call before the virus gets further down the lung into the little air sacs and the alveoli. If it makes it down there, which is the nature of these nastier viruses, the body doesn't have as much of these sort of frontline defense mechanisms, but it compensates by if a virus gets into the lung right down low in the lung system, in the alveoli or the small bronchioles, then the composite reaction to that is much bigger. And so you get a lot more cytokine release and a lot more interference because the first line defense is gone. So my kind of analogy to patients is like the back door. The front door is kind of on the street and that has to be locked and that gives you your best defense. And you may leave the back door unlocked, but if you get into the back door, then you really got a problem. And so similarly with these sort of more severe viruses, we've got to watch out for those. And if we know they're circulating, then we know we've got to get onto it much more quickly. But as I said, fortunately, we're not seeing that in Australia. Now, the next two slides are for the people with a medical curiosity or an interest in immunology, or in some of the live audiences we've had medical students who'd like to understand the immunology of everything. The first thing I can say is it's totally impossible to read. And the second thing is it would take me about an hour to explain all the linkages. But if you do have an interest in the immunology to say how your T and B cells and all the various other supports within the system influence the likelihood of your infection and how unwell you're going to be, then this slide and the next slide, which I'm going to show, will give you some indication about that. That's all I'm going to say. The references are there if you want to actually follow it, to go and have a look. I find that patients don't want to know that much about the immunology. They want to know if they're at risk and that what we've got with the vaccine will work and how long it will take and how much it will cost. In terms of cardiovascular disease, we've known for some time that flu actually can trigger a myocardial infarction, and we've now got a better insight into some of the mechanisms of that. So the cytokines are prothrombotic, and so people who've got underlying coronary artery disease have often got small plaques within the arteries which can be unstable and triggered by a range of events. One of them is sort of like an illness, or particularly a viral illness, or an infection, and influenza is known to do that. And so these plaques can be disrupted. And the whole process is compounded by when you've got an infection, you've often got a tachycardia. For people with a range of risk conditions like chronic lung disease, you may have attendant hypoxia, and you'll often have a sympathetic activation as part of the process. So all of that increases the likelihood that people are going to rupture a plaque or actually get a clot for that and have a myocardial infarction. So, and more reassuringly, we found that when people actually have the flu vaccine, that risk is reduced. And so not only do we understand that flu can trigger it, but the vaccination that we give, the influenza vaccine, will offer you some degree of protection. Myocarditis is fairly uncommon, so that's kind of an infection of the muscle of the heart. If you're a marathon runner and you go running with a bout of flu, then you're going to be more at risk from that because of the hyperdynamic circulation. We don't see that as much in other populations. Other sort of areas that's a problem are people who've got some degree of renal impairment, and so people with grade 3 renal impairment, so that's less than 30 mils a minute of their glomerular filtration rate, that can actually be further shut down by a bout of flu, and people can be triggered into renal failure. In children, and we saw this particularly in the pandemic, there are a lot of a lot of kids who actually had vomiting and diarrhea through the process, and so it might look more like a GI illness. And so you've got to think outside the square to actually recognise that that might be influenza. It's not something which is affecting the intestine. I've talked about the renal one there. The other group is that it's well documented that people can have an episode of depression that can follow a bout of influenza, and that can happen quite a period of time afterwards. And so people who've got depression need to be well treated, and they need to be offered the flu vaccine. The encephalopathy mentioned there is actually really uncommon, which is reassuring, and it tends to happen in children and in young adolescents, but we don't see it very commonly. So in terms of being overweight, they were one of the two groups in the 2009 pandemic that really had a lot of problems, and there were a large number of those with flu that ended up in the ICU. So we now understand much better that both the adipocyte, the fat cell, and the leukocyte, which is the white cell, talk to each other through a whole range of hormonal and other immunomodulatory signals there. And so that sort of factor you can see in the text there in terms of what actually happens by being overweight is you've effectively got an impaired immunity to a number, particularly things like influenza. The other effect with being overweight is it's sort of like wearing a stiff jacket. The lung needs to aerate properly to maintain health, and if you're carrying a fair bit of weight, you have a fair bit of restriction in the total lung volume because you can't expand your lungs effectively, and so that increases your risk there. And so we found in the 2009 pandemic that quite a few people ended up in ICU. So they don't have a much higher risk of getting flu, but if they get flu, they're going to be much more severely affected by it. So they've joined the groups of people that we're actually recommending the vaccine for. Moving on to some of the issues, and some of these I've already kind of alluded to. We do have an issue with vaccine effectiveness, and since we've started to have the level of issue with vaccine effectiveness, and since we've started to have the level of surveillance both with the sentinel practices and the hospital networks, we've now been able to have the luxury of being able to measure how effective is the vaccine and how long does it last. And so I'll come back to the other issues shortly, but if we start with the effectiveness, the next couple of slides are courtesy of a colleague in CDC, Dan Jernigan, who's looked at the US situation where they've been monitoring this for a longer period of time. Now, to understand this is the kind of estimate of the influenza vaccine effectiveness as dictated by their seasons, and because their winter period straddles the end of the year and the beginning of the next year, that's why you've got dates like 2005, 2006. You'll see there's a point estimate with the blue dots there, and that's the average effectiveness. So the first thing you'll notice is that across the population, over that period, the flu vaccine's been somewhere between about 30 and 50% effective in preventing a case of influenza across the population. You'll also note that in some years, and if we have a look at the first one there, like 2004, 2005, the average effectiveness was very low, it was 10%. And then there's a bar there which actually straddles the baseline, the x-axis there. And so what that means is that this is an estimate of the vaccine. We don't necessarily get to record laboratory tests on everyone who's had influenza. We have a sample of people, and when you have a sample, if you repeat that process with a different sample, you might get a slightly different estimate. And so the 10% is your average estimate of how effective it is. The line represents your kind of best and worst estimates, and we call that the 95% confidence intervals. So you could say, if you look in 2002, 4, 2005, that the worst case scenario is that someone who got the flu vaccine, it was minus 35% effective. In other words, they were 35% more likely to get a case of flu than someone who wasn't vaccinated. Now that's possible. It doesn't make a whole lot of sense, and we can tell you that you don't get the flu from the flu vaccine, but it's you just need to be mindful that it is an average estimate. So the way we interpret that is that when that bar, that line, crosses the zero, then what we're saying is that the flu vaccine was no better than chance. And so a person who had the flu vaccine versus those that didn't, you are no more likely to get flu. Okay, so there wasn't really much effectiveness within that. And you can see 2004-5 and 2005-6, they were 2 seasons where the flu vaccine wasn't particularly good. And we can speculate on some of the reasons for that. Part of that might be what particular strain was circulating, so whether it was an H3 strain, which is pretty difficult to grow in eggs, so it's often harder to get a really good antigen against H3, and H3 causes a lot more morbidity than H1 generally, certainly in the recent periods. Or it could be that the match of the vaccine, so when they actually looked and say what's circulating, how well have they judged that? Because the flu vaccine is notorious, and we know that it drifts over the season and changes its stripes a little bit, and so it looks a bit different. And so at the beginning of the season, it might be that it matches really well, but later on in the season, when there's been some antigenic change because of genetic drift, it might not give you that much protection. But reassuringly, you can have a look over that kind of 12-year period to see that 10 out of the 12 seasons the vaccine worked pretty well, which means that the various committees deciding on which vaccine we use have matched up the circulating strains quite well to what's actually doing the rounds. So looking at the next slide, this is taking it by age group. So we first of all looked at totality, and the thing you notice, there are a couple of bits of information on this slide to pay attention to. You see the red box at the end of the slide there, which I'm highlighting with the mouse there. That's the over 65 population, and their average effectiveness was a lot less than the other groups, and so the others were in that range of about sort of 40 to 60%. But in the older population above 65, the vaccine effectiveness is 26%, and you can see that that confidence bar straddles the 0. And so that what we're saying there again is that it really, in the age group of over 65 in that year, the flu vax wasn't better than chance. It really didn't offer much protection. So the final bit of data in the slide there, if you have a look at the pie chart at the bottom, so the red here is highlighting that it was an H3 season, and as I've said, H3 is harder to grow on eggs, and it is associated with a higher level of morbidity, and most people who are elderly have had their kind of original bout of flu with an H1. All of those factors lead to the impact that it's not quite as effective in that age group as in younger people. If we look at the next slide, there we go. It's just stuck on me. Yeah. So if we look at this slide here, this is another influenza season here. And if you go back to the 65 plus there, the blue dot there is on 45%. And you say, well, how can that be? You know, it was much lower in a previous year. And then you have a look at the pie chart at the bottom, and in that year of 2012-13 in the US, the main circulating strain was the H1 strain, and so that was an issue that was that was the people in the age group over 65 had very good protection, so that was not a problem. So moving on to the next slide here. Oops, we'll just have a go. If we actually have a look across the seasons, and this is now looking just at the over 65 population, you can see in the years when there was a lot of H3 circulating, so that's when the pie chart was largely red, that there is the vaccine in older people wasn't working as well, and we can see that because the error bars, those vertical lines, cross the 0. In the years 2013 and again in 2015, when it was mainly H1 circulating, then there was a much better protection against the elderly. So having all of this data has really got us focused to say, look, we know there's been an issue with H3, but we really do need a better vaccine against the H3 strain, because what's happening is in our population with the highest morbidity and mortality are not getting much protection from the vaccine, and so we actually need to do something about it. So looking at the next element, so we talked about the effectiveness. The other question is, how long does the flu vaccine last? And so while we've had a bit of a delay to the season this year, you can actually you need to ask the question, how do we get 6 months of protection or 12 months? Now in the live audiences I would normally ask people, and we get a show of hands, and most people think you get about 6 months, and that's probably about as best that you are going to get. And so if we have a look at the next slide coming up there, it's a bit hard to see, but if you kind of focus, let's start with the one on the right hand side, and you can see my mouse is hovering around. There are groups of 4. These are all different seasons, so that the first bunch is one season, this is the next season, this is the season afterwards, and this is the final one they looked at, which was 2013-2014. This bottom bar here is the time frame after the vaccination, and that's more than 6 months. And you can see that the point estimate of effectiveness sits to the left of that line. And so largely what that's telling you is the vaccine was not effective in any of those seasons beyond 6 months. The graph on the left-hand side of that is really breaking that down by age group and by the strain of virus. And so there's some very recent evidence that we're saying at best we're going to get 6 months. It's probably highlighted even more sort of cogently in the next slide. It's presented differently. This is in a separate paper that's come out this year. This is now breaking down the effectiveness of the vaccine over the time period by the strain of virus. And so if we look at the top graph here at H3N2, the figure on the y-axis is the effectiveness. That's sitting at around 45% at the time the person gets the vaccine, and you can see the x-axis across the bottom here, these are number of days, and so 3 months sits about between 100 and 150 days, that after 3 to 4 months there is quite a bit of further decline, and that's of the order of 5 to 7%. So in effect, if you're saying to someone with a vaccine, well, you get pretty good protection for 3 months, but it's going to decline after that, and the previous slide has shown you that really there's not much benefit after 6 months. And so when people are asking for the flu vaccine in January, there's not much logic in to offer it to them in January, because the peak of the flu season generally is probably somewhere in late winter, although there can be flu circulating at any particular time of the year, but the peak of it's going to be probably mid to late winter and early spring. The decline in immunity against H1 wasn't as marked, and so again, here's the 3-month period here, and that's dropped down, and that's still around 50%. So you had a higher level of effectiveness against the H1 strain, which is just consistent with the other data that I've presented to you. And but there still has been a bit of a decline. And in the B strain, which is the bottom curve, there's been not quite as much of that. So in all 3 strains in the vaccine, it is an issue that the vaccine will not last, certainly not last more than 6 months, and there is a decline after 3 to 4 months. And so it really begs the question, should we give people an additional dose of the vaccine? And unfortunately, the evidence for that is not there. It's a bit like adding double the dose of fertiliser. The plants don't grow twice as well. The exception to that would be probably someone with HIV or someone who's significantly immunocompromised. There is some suggestion it is reasonable to offer them a second dose of the vaccine. But in the adult population, there's currently no recommendations to do so, because largely we haven't seen the benefit from that actually happening. So this is data from Alan Cheng in Monash, and it's really looking at the last 2 seasons, the next 2 slides, and really just again breaking down how effective the vaccine was from the FluCan data that we've had from the hospital networks, and which groups seem to get the benefit. And so if we look at all patients, that's the top horizontal line. So this time the kind of average vaccine effectiveness is indicated by the red bar there, and reported in the text there of around 24%. And so in all patients it was effective. It could have been more effective, but 24% is what we got. It was very effective against influenza with the H1 strain, but not very effective against H3. And you can see here with the blue line here that again the vaccine, the error bar here crosses 0. And so largely we're saying, look, H3N2, it didn't seem to really have much benefit. And that's most marked in the older population who are most vulnerable from that strain there. So when we look at that in combination with the next slide, this is now looking at people who've had the vaccine over a couple of years and where they're getting it regularly. And the nuts and bolts of it is if you actually had the flu vaccine in most years, so if you look here both the current and the last year, you have a level of protection which is higher than someone who's had it just in the last season or just in this season. And that holds for the whole population, but reassuringly it holds in the higher risk groups like the elderly. And so even though the error bar crosses again, the vaccine error, it doesn't cross 0. It's looking at the average effectiveness there, it's actually higher effectiveness when people are getting it both years than when they get it just in one particular year. That also holds for people who were not in the older age group, and it also holds for people who've got chronic illnesses. So the take-home message to patients is don't cherry-pick the season because the media says it's a bad year. We have influenza admissions and deaths every year. People should be getting the vaccine every year, and there is a benefit to do it. It doesn't diminish your immune system by actually having it every year. In fact, this is good data to show that it gives you extra levels of protection. So having recognised that we don't have a perfect vaccine, and we have some way of actually improving it, the companies have actually looked at strategies. And so the ones highlighted in red here are ones that are currently kind of in train and undergoing clinical trials or before the TGA to look at ways of boosting it. So an adjuvant is turbocharging the material that you put in the vaccine to present it to the immune system when you inject it, to try and get a greater response from the immune system and build antibody levels. The other one that's currently in clinical trials.
John, sure. Can I just interrupt for a moment? There's
Sure.
just one little question in regards to waning immunity and vaccine effectiveness, being asked to whether the effectiveness has declined since the advent of the H3 strain coming into the vaccines.
I think the evidence, well, the second slide I showed on duration showed that there was a decline in both H1 and in B, but it wasn't as marked. And so H3 is particularly problematic because it's quite hard to grow in eggs, which is the culture medium they use to grow it. And so I think it's fair to say you can't single it out, but largely, you know, the statement you can make is that the flu vaccine will be certainly good up to 6 months, but there is some decline after 3 months, and it's more noticeable against some strains than others, and we won't often know which strain is circulating until a couple of months into the season when the WHO have typed all of that.
Okay, thank you.
Okay, so the other choice is to try and turbocharge the antigen. And so for those of you who were in the webinar last year when we talked about Zostavax, you'll remember that we talked to you that the Zoster vaccine has 14 times the antigen dose that the varicella vaccine. So it's the same virus, but it needed 14 times the dose to give you a good priming booster response in older populations. And so one of the companies is actually looking at a higher dose of the antigen within that to try and increase its effectiveness. There are a couple of other ones there, just a few worth commenting on. The live attenuated vaccine is the only, that's the only other kind of non-injectable vaccine that's actually on the clinical market, and that has its own story, and I'll talk about that because it's been used in Russia for many years. It has been recommended in the US for the last 4 or 5 years, but has been withdrawn for this last season, and it's being trialled by the UK in young school children, and I'll present some data shortly to show that you're actually getting different levels of protection depending on the setting you're in. The other one is the intradermal one. So you'll remember we had Influenza a couple of years ago, so that was a very fine needle injected intradermally, and intradermally is a very active immune zone, and the company was optimistic because they found actually higher levels of antibody titers against the flu, but the antibody titers are only a proxy measure for infection. There's a lot of debate about how well they actually measure that and whether antibodies really reflect the likelihood or the level of protection that you've got. But that hasn't borne out, so the intradermal one hasn't led to the level of protection that we would hope in terms of clinical endpoints, and so that's really not as much of a contender. So the two ones are the adjuvanted and the high dose one, and they're summarised in this slide. So the high dose one is a Sanofi product, and that's currently been looked at by the TGA, and that's a 4-valent vaccine, so 2A and 2B strains, and that's actually had some data. So the evidence from the US is that it was 22% more effective in the 3-valent version, so not with the 2B strains in it, than the normal vaccine in terms of preventing hospital admission. So that was a clinical endpoint to say this was a better vaccine. It was more effective at stopping high-risk groups ending up in a hospital setting. The other vaccine is the adjuvanted vaccine. So that's where they're turbocharging the products that go into the vaccine in addition to the flu antigen. And Seqirus have got a vaccine which has been available in the 3-valent form, so 2 H1 and H3, and also one of the B strains, but they have to add in another B strain because of the now Australian requirements, and they're working on submitting that to TGA. So in a nutshell, none of these two vaccines are available in the current season and will not likely be available next year. It's a work in progress, but it's reassuring to see that the companies are trying to make a vaccine where we get a better level of protection than around 50% in the average population, and in terms of reducing complications in the high-risk population. So looking at the next slide, the other problem we've got is coverage, and so you can have a look. So the top of the graph here on the y-axis is 80%. That's really the target level, and the only group that are reaching that are people over the age of 65 who've got some other chronic disease. And so they're at very high risk, and so it's reassuring they've got good coverage. But if you look at the blue bars, they're in children, and so in kids that have got healthy children, it's really low. In healthy children, it's only around 17%. And in the adult population with chronic disease, and this is a very sizable group of people, so this is the green bars here, we've only got about half of them. So we're about 30% short of where we need to be. And similarly, in the people who are just in the general adult population, the level of flu vaccine coverage is only about 1 in 3. And so, unlike in children where we've got really high levels of coverage, we are not getting the levels of coverage that we need. So this kind of highlights it. This is data from New South Wales, and largely the vaccine levels in over 65 has plateaued. Now, if this was a childhood program, that would be unacceptable, but largely we're not encouraging adult vaccines as much. Rhino McIntyre and Rob Menzies have had a paper in the MJA just recently to highlight that the adult vaccines are really neglected, that they are the largest source of vaccine presentable diseases, and we're not paying the level of attention to them that we should be. One of the kind of things that supports that is that the last national adult survey of vaccine coverage was done in 2009, and we do that much more frequently in children's programs. So we've got a long way to go to try and boost the coverage. We need better data, and we need the sort of data like the CDC is presenting so we can actually improve the coverage. So this is some of the figures by different groups. And so in children, we've got who've had only 1 or 2 doses, because you know that children under the age of 9, when they're first exposed to the influenza vaccine, need 2 doses because they react to the injection more than adults. That rate is only about 1 in 8. In pregnant women who are very high risk, and I'll talk a bit more about that shortly, we've only got a coverage rate of around 40%, which is way too low. In the Aboriginal populations, that does vary. It looks to be reasonably good in the red bars there, saying 71 to 89%, but you'll notice that the data was only collected nearly 10 years ago, so we don't actually have more recent estimates. And amongst healthcare workers, where everybody should be getting the flu vaccine, amongst GPs, it's probably around 75%. Amongst other specialists and hospital staff and nurses, it's much less than that. And so for all sorts of reasons, healthcare workers need to actually be covered against flu because of the risk of actually spreading it to their population. So they suffer as much flu as the rest of the population. And as I've said, because flu doesn't always look like the classic illness that lays people up in bed, they may go off to work with a more sort of seemingly trivial illness, and they unwillingly spread the vaccine to other people within the setting who are often people at high risk. And so going to work when you're unwell is not uncommon amongst healthcare workers because you're often short-staffed and you don't want to let your colleagues down. But at the same time, those who do take the time off there, when you are short-staffed, it has a bigger impact on those remaining. And so it actually saves money to have a workplace flu campaign from the employer's point of view, and it's good sense from a clinician point of view. And there are a range of ethical reasons. There's a duty of care that you shouldn't be harming your patients or exposing them to unnecessary risk, and that you really should be taking the best interest of their health at all times. So for all of those reasons, we ought to have 100% coverage. In British Columbia, Paul Van Byner, who's now the head of the Immunisation Coalition, was the public officer of health there, and he ran a policy there that if you worked in the hospital setting and influenza was around, if you chose not to have the vaccine, you'd have to wear a mask for the whole 6 weeks. It had an amazing effect on people's decision to get the influenza vaccine because it's quite a considerable imposition to have to wear a mask for that whole period of time. So moving on, if we look at this is the French study I alluded to. This is a graph of what happens when you have people who have influenza spreading it. And so the baseline here with nobody, that's the first dot there without any bars attached to it, nobody with flu and nobody with healthcare worker, no patient or no healthcare worker with flu, that's the reference case. As soon as you have a healthcare worker with flu, then the risk of people within that ward or environment acquiring influenza goes up sixfold. And if you have one patient now affected, because that's quite likely one of those patients gets affected, and you've still got the staff member, you've got more than one patient with flu, that increases 18-fold for everybody else because they're often in a fairly contained environment. And when you have staff and the patients with influenza, then your risk goes up 35 times. And so the randomised trials looking at nursing homes have shown we get good protection by vaccinating staff, even when you've got high levels of vaccine coverage in older populations. And so it really is a requirement that people working with vulnerable patients ought to get vaccinated every year. Now, if we look at kids, I talked about the sort of children being a really big sort of issue. They are the ones, particularly in really younger age groups, that have the highest rates of flu. This is the flu cane data over the last couple of years. The first thing to note from the graph is there's much more areas in the blue than in the red. And so children ending up in hospital, there are more children that are healthy than kids with comorbidity, and because the high attack rate in children, you actually get a lot of kids admitted to hospital with influenza who don't have any underlying illness. And again, really underpins why we should be thinking about offering the flu vaccine to that group. If the kids did have a comorbidity and they got into hospital, they're more likely to end up in ICU. And again, when they had a look at the program of how effective it was, they actually found that it was about 55%. And so if you did cover the population, then you're going to reduce the number of kids admissions by about half. And in a busy flu season, that's quite substantive and an aim we should actually work towards. So I talked a bit earlier about the live attenuated vaccine. So this has been available in Russia. In the US, they actually pulled it because the last few seasons, when they actually monitored its effectiveness, despite the initial high level of effectiveness, it's been very poor. It's been around 3%. And so the equivalent of a ATAGI in the US, ACIP, has said to the manufacturers, we're not going to offer your vaccine as part of the program. You have to really do something to improve its effectiveness. And so they're having a look at it in that setting and not offering the live attenuated vaccine. And this is a vaccine you can give intranasally, so it has the advantage of not having to be given intramuscularly, and it has an effect. It actually gives you some herd protection because it actually leads to mucosal responses as well as antibodies. When you have an injection, you get antibody levels against flu, but when you actually have it intranasally, you get the local antibody production. You reduce the spreading to other people, and also because of that route of administration, you actually get some cross protection against other strains. And so there are several advantages of offering a vaccine that doesn't have to be given invasively. In the UK, though, they've had a different kind of picture to that. Because they've seen some initial evidence of effectiveness of the live attenuated vaccine, they've offered it to children in the school age group, because there was a study a number of years ago in Japan where they offered the vaccine over a 30-year period. And so in the 60s and 70s, pretty well all school children were offered the flu vaccine, and they got high levels of coverage. And then because no one else in the world was doing it, they decided, well, maybe it wasn't such a good idea, and they stopped it. And what happens is that when they plotted the flu vaccine coverage in those children, particularly school-age children and younger children, against the mortality in older populations, when there were very high levels of coverage against the flu vaccine, the mortality in older populations went down. And so there was evidence of a herd effect to really suggest that there is a benefit by getting large levels of coverage amongst children. And so the UK have been encouraged with their program to actually start a program offering it to kids under the age of 6 in particular, because they're kind of super spreaders. So this is a bit hard to see, but if you look at the final column there, they've had very different results from the Americans. So they've actually seen that the flu vaccine, and irrespective of the virus and irrespective of the age group, and these are children in this sort of study under the age of 6, you're getting 45 to 60% protection against a vaccine that's got a very high degree of acceptability. And so it actually, it's a different sort of picture that we're getting to the Americans. And so unfortunately we don't have live attenuated vaccine in Australia, but we really need to watch the UK experiment to see, does this offer protection to other populations? And from the American situation, why is a live attenuated vaccine not working? So that question needs to be really answered. Now, pregnant women are probably one of the highest risk groups. And so 3 things happen when a pregnant woman gets a bout of flu. It actually causes a significant cardiovascular load on their system.
Sorry.
Sorry?
Letting you know 7 o'clock and a request for a couple of minutes break.
Okay. Do we want to have a 2-minute or 5-minute break?
Yep,
Or
just so they can refresh their cups of tea would be absolutely fantastic if we could.
okay, so I've got 7:03 on my clock here.
Yep.
Should we start again at 7:08?
Yes, I think that would be fine. Thank you.
We'll bring the curtain down for 5 minutes and we'll be back at 7:08.
Thanks, Luke.
So welcome back everybody. So hopefully we're all on the same page. You should be now looking at slide number 45. And so we're just talking about pregnancy and why they're a very high risk group. So three things happen to pregnant women. They have a cardiorespiratory insult by getting a case of the flu, and so it actually puts them in hospital much more likely than other people. As a part of the process, the flu can trigger premature labour and stillbirths and people having a caesarean section and preterm delivery, and so that has an effect on the fetus as well as the mother. And then finally, because the baby in the first 6 months can't get a vaccine, because the vaccines really only start at the age of 6 months, then if you give a flu vaccine in pregnancy, the antibodies transfer via the placenta and give the mother some degree of protection. And we've seen from the studies actually get up to the protection up to 6 months. So while I did say that the duration of the flu doesn't seem to last 6 months in the adult population, in the studies we've done where women have been immunised during pregnancy, is that benefit seems to spread out to the age of 6 months against children to protect them from flu, and that's a group that are very high incidence of influenza. And so because we can't offer them a vaccine, immunising in pregnancies has that triple benefit: the benefit to the mother to stop them being admitted to hospital, the reduction in obstetric complications, and a much better outcome for really young children. Just to be mindful that in the 1918 pandemic, of the women who died from influenza, half of them were pregnant at the time. So it is a significant issue in pregnant women. So the things that make a difference for pregnant women is actually healthcare workers making a recommendation. And so we've often said, previously, don't take things during pregnancy, or we haven't recommended it, or we're worried about safety. There's no safety signal, so that the meta-analysis of looking at safety in pregnancy is the flu vaccine is absolutely safe. There are no signals to suggest it's problematic. And a lot of people don't actually understand the impact of flu during pregnancy, so having that sort of information is really important to pass on to that group of people. So moving on to the next slide, this is the kind of adverse events you get from flu, and so effectively you really are going to see local reactions as being the main one. We're very lucky that severe reactions like allergic responses and possibly anaphylaxis are relatively uncommon. And so you get a local swelling and redness, and that largely is an effect of the adjuvant and the vaccine being injected. It's not the person actually getting influenza, even though they might get some of those other sorts of symptoms. It's more pronounced in young children because they're more naive to that, and so, but as I said, very few serious effects. If we look at anaphylaxis, the guidelines have changed, and if they've had a true anaphylactic reaction, then if they're actually in a safe environment where you've got all the usual kit of adrenaline, IV fluids, and ability to monitor them, then the handbook has recommended you can actually give those people the flu vaccine, but you do need that sort of monitoring process. Really, there are very few other contraindications to the vaccine. Guillain-Barré is a potential exception. Guillain-Barré was seen in the 1976 swine flu pandemic, and the association was fairly weak, and it appeared that it occurred in about a rate of 1 in a million doses of giving out the flu vaccine. It hasn't been seen in other pandemics, and really its impact is relatively modest. But people with Guillain-Barré syndrome actually have a risk of getting it again, and so it's something which just warrants a further discussion. So moving on to slide 49, I'm going to leave this mainly to Andrew to talk about. These are the strains in this current season, and there has been some changes, but there'll be two A strains represented by H1 and H3 and 2 B strains. I'm now going to cover pneumococcal. Andrew, were there any other quick questions on flu before I move on to pneumococcal?
No, I think we've answered them all. Yep. It was just about which trimester is best, but we're okay with that. No, we'll keep sailing. I think, John, keep going.
So talking about pneumococcal disease, pneumococcal in adults it's largely a respiratory illness, and so the large blue circle here is a community-acquired pneumonia. That's the biggest morbidity associated with pneumococcal disease. So about 80% of people who've got a pneumococcal pneumonia will not have a bacteremia. In other words, they won't have the pneumococcus in the blood. Invasive pneumococcal disease, where we have better monitoring, that is much less common than community-acquired pneumonia, probably about a tenth the total incidence. And so when pneumococcus gets into a sterile space, like into the CSF or into the pleura or into a joint space or into the blood, then it's regarded as being invasive, and that probably accounts for about, at most, 5 to 10% of the disease. And so this pattern has changed a little bit there, but largely what we're giving the pneumococcal vaccine is to prevent pneumococcal pneumonia, but certainly invasive pneumococcal disease is quite significant and problematic. We have 90 serotypes of strep pneumonia, the pneumococcus. 23 are mainly the bad guys. And so over the years, the vaccine has actually changed, where we've had fewer serotypes within the vaccine, but in the last 25 or 30 years, we have 23 strains or 23 serotypes in the Pneumovax vaccine, which is the vaccine which is conjugated, or the antigen which is conjugated with a sugar molecule. And so when I talk about the 23 valent vaccine, I'm going to be talking about the vaccine that has a sugar moiety attached to it. And the thing to understand about that is that that sort of vaccine does not induce B cells. So you don't get an immune memory. You get a production of antibodies, but you don't get immune memory, and you don't get protection against herd immunity, because you don't have any impact on nasal carriage, which is affected by the other vaccine. The other vaccine, which I'll talk about shortly, is the conjugate vaccine. So the conjugate is where the pneumococcal antigen is attached to a protein molecule, and so that boosts B cells and it boosts antibody production, and so you get a longer duration of immunity, and you also get mucosal protection, and that accounts for some of the reduction in pneumococcal disease in populations that haven't been vaccinated, so particularly the older population. So in invasive pneumococcal disease, the case fatality rate has remained high, and so it hasn't really changed over the last 30 years. It's even higher in kids with meningitis. Fortunately, the actual incidence of meningitis has actually gone down quite substantively. And part of that is due to the fact that we're actually getting increasing antibiotic resistance. And so, you know, some of the last data we've got about 10 years ago is that at least 10% of the isolates of pneumococcus are no longer susceptible to penicillin, which has been the mainstay for over 50 years or so. And worryingly, some of the cephalosporins like ceftriaxone or cefotaxime, the antibody resistance to that is actually also growing. So that is a problematic issue. So moving on to slide 53, and this is I'm going to show this twice. This is the kind of key slide in the data. And so there are a number of things to follow here. The y-axis here shows you the rate of invasive disease, and if you have a look at the population, we're talking about elderly population, those over the age of 65, and we're talking about the Caucasian population. On the x-axis is the timeline starting in 2002 and finishing in 2004, where we've got some data. And if you have a look, we introduced Prevnar, which is the conjugate vaccine. And so that in its first iteration was PCV7. And then we had in 2011, we introduced PCV13. So they added some serotypes. And again, the PCV13 is the conjugate vaccine with 13 serotypes, as opposed to Pneumovax, which is the 23 valent. Now you can see in the top curve there with the round circles that the rate of decline in invasive disease was quite substantive after the introduction of PC7, and was less so and delayed a little bit after we introduced PCV13. And so there's been quite a reduction in the total amount of invasive pneumococcal disease. And so you can see it's been reduced by about 50%. So that's the good news. And if you have a look at the curve with the black circles filled in, that's the strains that were in the 7-valent vaccine. And so we've largely knocked them out. And so by the time we've got down to 2014, very few of the cases being reported in invasive pneumococcal disease are due to serotypes that are contained within the PCV7 vaccine. The diamond bars here are the ones that were in the 13-valent vaccine, which weren't in the 7. So the extra 6 serotypes that have been added in. And you can see there's not been as as much of an effect, but you can see from about 2012 onwards, there's been a small decline in the amount of serotypes due that have been included extra into the PCV13. So what that's telling us is, in an older population, by vaccinating children and getting good coverage, we've seen a decline in the serotypes causing pneumococcal disease that were in the vaccine. That has declined quite substantively. The bad news is, if you look at the black squares filled in here, this is the non-vaccine serotypes. And so what's happened is that when we've knocked out the bad guys, some of the other serotypes that are circulating have now taken an advantage, 19A being one of those, which is not in the PCV13 vaccine, and so that's actually causing some disease. And so we're not seeing the level of protection against some of those other serotypes as they replace the ones that were in the original PCV7 and subsequently PCV13. So it is a good news story. We've had a decline in invasive disease, and we've got better data on invasive disease than community-acquired pneumonia, but you can actually see there's been quite a substantive reduction, and that's happened in the older population, so that's been a win. So we've reduced the nasty invasive disease in children, particularly things like meningitis, and we're now seeing a similar decline in the older population against invasive pneumococcal disease. So moving on to the next slide, which is number 54. This is sort of saying it in another way. If you have a look, how much of the community-acquired pneumonia is caused by pneumococcal? Because if it's not pneumococcus, we don't have a vaccine against it. Well, prior to the introduction of PCV7, about a quarter of pneumonia was due, however you kind of sampled it, either by blood culture or a urine antigen test or a sputum culture, about a quarter of the isolates would show pneumococcus. And now when we look sort of after that period, having had the introduction of the PCV7 and subsequently PCV13 vaccine, that's nearly halved. And so we're taking out the pneumococcus because of the vaccination of children, and so it's really saying community-acquired pneumonia is actually now happening due to other causes, that which are largely not affected by the vaccine. We'll skip over this one because I think that's we can just leave that out. This was the original pivotal study, slide 56, where it was done in South African gold miners back in about the 1970s. And so while it says it's a 13-valent, this was the polysaccharide vaccine, the sugar vaccine. So it subsequently morphed into the 23-valent, but the 13-valent showed very good protection against bacteremia by having pneumococcal in the blood. It showed a similar sort of reduction in what they thought might be due to pneumococcal pneumonia, and when they used a criteria of having X-ray confirmation, then the reduction in pneumonia for those that got the 13-valent polysaccharide vaccine went down by about 53%. And this was done in about 4,500 patients, so that was good enough evidence for a lot of countries to adopt the pneumococcal vaccine, the pneumococcal subsequently 23 sugar vaccine in adults and older populations to provide them some protection against both pneumococcal pneumonia and against invasive pneumococcal disease. So in the Netherlands, it was a slightly different story. In the Netherlands, they didn't have a program for the pneumococcal vaccine in older population, and they've really been a bit delayed in getting their child program going. And so they ran a very large study called Capita, which had around 85,000 people that were randomised into one of two groups. And it was double-blind and placebo-controlled. And so half the group got the conjugate 13-valent pneumococcal vaccine and half the group got saline. And they measured the endpoints and they followed them up in total for about 4 years. They've now got data for that period of time. And it was very effective against invasive pneumococcal disease. So there was a 75% reduction. And so that was very similar to what they've seen with the polysaccharide vaccine, the Pneumovax 23, in that it is very effective at eliminating invasive pneumococcal disease. Against community-acquired pneumonia that was caused by the vaccine type, so that's the data in red, there was about a 45% reduction in community-acquired pneumonia due to the vaccines within the 13-valent vaccine. It's about 42% for all community-acquired pneumonia, and that's really saying that a lot of the strains that cause pneumococcal pneumonia are the ones that are actually in the vaccine. So the vaccine was quite effective at that. There was no difference in all-cause community-acquired pneumonia, and there was actually no difference in total mortality between the two groups. So on the basis of that, we now have two... Go.
John, sorry.
Sure.
John, can I just interrupt for a sec? Just giving you just the heads up that it's currently
Okey-doke.
7:23.
Thank you. So this, yep, this is
Alrighty.
so this is slide 58. This is quite detailed and actually shows a summary of the data. So let me go through this fairly quickly. So I've just presented the capita data. That's the conjugate vaccine. That's that second column here. And this is its effectiveness against invasive pneumococcal disease and community-acquired pneumonia. And so there's good protection against invasive disease and around 35 to 45% against vaccine type. If we look in the final column, that's the polysaccharide vaccine. That's Pneumovax. Then we've got similar levels of effectiveness against invasive disease. But when we look at community-acquired pneumonia, and what they did in the Cochrane review when they analysed the data is they actually grouped the studies by different countries and time periods and incomes. And so if you're living in South America or Southeast Asia or one of those other, or Sub-Saharan Africa, then pneumococcal vaccine is 46% effective, which makes it very similar to the conjugate vaccine Prevnar. If you look in countries like Australia, Canada, New Zealand, then the effectiveness was around 29%. And you can see in the confidence intervals that there's a negative number to start with, which means this isn't any better than chance. There is some benefit, that's the average effect, but there's a possibility, there's a kind of a 5% chance that it will not be effective at all. And if you actually look at the group with chronic disease who are also in places like Australia and the UK, then the vaccine effectiveness drops even further from that. So it is a bit of a worry that when we look at the pneumococcal vaccine, it really depends on the population, and community-acquired pneumonia is the main thing we're trying to prevent, and so the kind of biggest benefit will really vary about the group. So I'll skip over this one. There's a whole range of reasons for that, and it's led to a fair bit of debate. Some of it, and if you have a look at here, you've got two red rectangles here. Two of the studies, the Kraser-Melamed paper and the Schiffer paper, were subsidised by Pfizer. And that's the opposition group to the pneumococcal vaccine, and they showed effectiveness by the studies they included in their reviews of a lower effectiveness than studies that were non-aligned, that didn't actually have any pharmaceutical representatives on their authorships or conflicts of interest. And so there's a fair bit of contention about working out how effective the pneumococcal vaccine is, and it depends on which studies are included and why you exclude them, which has led to a fair bit of debate in that process. And so the kind of best evidence we've got, which is the Cochrane, which is the most unbiased, is that we don't seem to have good benefit in rich countries like Australia or First World. But a lot of the studies are underpowered. It may have some benefit in Australia or First World. But a lot of the studies are underpowered. It may have some benefit in some groups. And because we have to look at the range effect there, we don't know whether it could be up to 42% as effective if we actually had a very large sample size to be able to demonstrate that. So moving on to the next slide, I might skip over that. Largely what it says is that by having an extra bit of data in a randomised trial, that didn't actually change the results very much, and so we're not helped by the process. So the other differences between the two vaccines is that the conjugate vaccine, Prevnar, we've got about 4 years of data and we've got good protection up to that period of time, but we need further data beyond that to see whether we're going to remain to have that. In the pneumococcal vaccine, it's more problematic, and so it looks to be somewhere between 2 to 5 years, and that's largely in people who are healthy, 65 to 74. As you get older and you have more immunocompromise, then the duration of immunity probably declines. The other comparator here, particularly from the slide, is that the conjugate vaccine gives you herd immunity and elimination of nasopharyngeal carriage, which doesn't happen with Pneumovax because it's related to the sugar molecule and you're not getting the B-cell priming of that. And yet in the Prevnar, the 13-valent one, we've actually seen other strains come into the picture that are now causing some of the disease. We haven't seen that with the 23-valent. And so it's actually leading to some sort of confusion. I'm going to skip the next few slides and I'm going to take you up to, just because we're going to catch up on a little bit of time here. This is now slide 67. This is looking at some of the other problems that have been seen with the pneumococcal vaccine, the polysaccharide vaccine, is that after repeated doses you do tend to get much more of a local reaction. And so this is data from a paper where they found that 74% of people who had a second dose had local soreness, and it was probably related to the timing about how long after they got the first dose. If you look at more severe upsets, things like headache and myalgia were pretty similar. Fatigue was sort of higher, but they weren't really significantly much greater in that. And on the basis of that data, the Australian government took out the second dose of pneumococcal vaccine, Pneumovax, in 2011. Now here's a paper that was done around that period of time where they actually looked at a 10-year gap. So this original study was done 10 years earlier in the extension, and you can see that the side effect rates after the first and second doses, you saw the same effect as the previous slide. But in this group with a little green square here, is that this is a group that had their second dose of the pneumococcal vaccine about 10 years after the first dose, and their reaction rate for a second dose was about the same as the first dose. And so the time interval between when you give it does influence that, and it has been recommended around 5 years, so it should probably be less of an issue, but we're only actually recommending the person has a pneumococcal vaccine twice in the average population, so that they're only getting a fairly limited duration of protection. So I'm going to leave out HOPA responses because of the issues of time. Just looking at the coverage, the blue bars here, we've seen the earlier one for flu was up around 75%. Pneumococcal has been much less than that. And you can see the arrow here, that's when they took out in 2011 the second dose of the pneumococcal vaccine, and the levels have actually declined. And so our current estimates is that probably only about 60% of the population over the age of 65 have ever had a 23-valent pneumococcal vaccine. So that is an issue. I mean, it is a problem that we actually ought to be getting a higher level of coverage than that. And people can't remember. I mean, people can't remember when they've actually had it. They think it's often the flu vaccine because it's the vaccine that protects pneumonia. And so it really will be important that we capture this on the register, and Angela will talk about that. So Angela's going to do this in detail, but leaving outside the at-risk groups that she's going to talk about, someone who's healthy, who's age 65, should have one dose of the 23-valent, the sugar pneumococcal vaccine or Pneumovax. They should not have a booster, but if they're an Aboriginal person, then they should get a second dose 5 years later. So looking a bit further on, looking to the next slide, I've shown that figure there. That's just to really highlight that the main benefit of this vaccine has been the herd protection in giving the kids the vaccine and getting protection in the elderly because of the reduction in nasal carriage. Now, just to talk about the Prevnar, just how long we're going to get some benefit from that. A group have just recently published a paper where they've said, well, because there's a decline in the serotypes that are in the 13-valent vaccine, is that sooner or later that's going to disappear. And they've estimated by some modelling techniques that if you have a look here, in about 10 years' time, 90% of those serotypes in the 13-valent vaccine are going to be taken out of the community. And so you're no longer going to get any protection, because if you give an adult Prevnar, most of the circulating strains are not going to be in the 13-valent. They're going to be other ones, and so they're not going to get a whole lot of benefit from that. So that's one of the issues around giving Prevnar to the older population. So in a nutshell, it is a problem. The PBAC are currently deliberating about what we're going to do and whether we're going to sort of replace the 23-valent vaccine with PCV13 or Prevnar in the older population. And you can see there are pluses and minuses on both. Ideally, as a clinician, I would like one of each with a time frame between the two of them. The problem with that is that the way the vaccines are worked out in the Australian context is it's got to be shown to be cost effective. And in a nutshell, it's going to be very difficult to show having two vaccines in the whole population is going to be good value for money. So I'll be watching what the PBAC with some degree of interest, but it's likely they're going to punt for one vaccine over another. Angela's going to cover that. I'm just going to show two very quick final slides, Angela, before we hand it over to you. Back in 1998, we did the first national influenza and pneumococcal survey in adults. So we surveyed about 4,500 adults in 200 practices, and we got their views about both flu and a pneumococcal disease and the vaccines. And so the take-home messages for the next two slides is how important a healthcare recommendation is. So if you have a look at the first comment here, I do not need a flu injection as I really get sick. Now, if you disagree with that, that's what we got as a positive. In other words, you do think, just because you are healthy, you still need a flu vaccine. So people with a negative attitude, so if they believe they don't need it because they really get sick, and their GP didn't talk about the vaccine, 6% of those got the flu vaccine. If they had a positive attitude, in other words, they didn't believe that, they thought they were at risk even if they were healthy, then about 60% in round figures would get the vaccine even if the GP didn't discuss it. but in the presence of a negative attitude, so if you have a look over here, only 6% with a negative attitude got the vaccine. When the GP recommends it, that figure jumps up to 58%. So it's almost reversing the attitude. And so you'll see that's repeated for most of these other things about whether the flu vaccine works, concern about discomfort, about their risk of pneumonia or getting unwell from the vaccine, that largely where you have a GP recommendation, even in the presence of a negative attitude, and that's this column starting with the 58.3%, is that people are going to get very high levels of vaccination compared to when there's no recommendation. And if we have a look at the pneumococcal, that's even more exaggerated. So this is the same 4,500 patients. And here, again, if we look in the final two columns here, if the GP or practice nurse doesn't suggest it, then even patients who have a positive attitude, in other words, they believe healthy people can get pneumonia, they believe they're at risk from the flu vaccine, this is the number of people that got it. And if we shift across to these two columns here with the GP recommendation, even when they had a negative attitude, in other words, they don't believe healthy people can get pneumonia, or they don't believe they're at risk, or they believe they can get the vaccine, they can get the flu, or they can get pneumococcal pneumonia from the vaccine, if a GP recommended it, you can see that by and large people will accept the vaccine. And if they have a positive attitude, that rate is even higher. And so the take-home message from these two slides is it's very potent, the impact of a healthcare professional recommendation. It actually counters a lot of the negative attitudes to that. And the other side of that is that when you don't recommend it, people think that you don't think it's needed for them, that you've made a decision for them, and if it was important, you would have raised it, and therefore they don't raise it. And so it really brings home the value of the healthcare recommendation. In the study here, we found with flu, when we adjusted for all the other predictors of influenza vaccination, and we put that into a multi-regression model, the flu recommendation from a GP increased the likelihood of the person getting it sixfold, and the likelihood of getting a pneumococcal vaccine was increased tenfold by a provider recommendation. So that's the end of my slides. We've caught up a bit of time. Here's the acknowledgements of the various slides that have been contributed by other colleagues to my talk. I'm happy to take any other quick questions. Otherwise, we'll hand it across to Angela to give her a bit of time to cover kind of implementation. So I had a couple of extra slides with things there, so she's going to just whip to hers. In the meantime, has anybody got any specific or burning questions around pneumococcal?
There's a few just commenting what a great presentation it was, John, that they've found it very interesting.
Okay. Perhaps in the interest of time, if that's fair, perhaps we'll just get you to go and to lead on, and I'm happy to hang on at the end of the talk, and if there anybody who've got any questions, for those that are interested can stay, but for the bulk of people who don't have questions, we can try and finish close to time.
Sounds good. No worries.
Okay, I'm handing the baton to you.
Okay, thanks, John. Okay, so we'll just do a real quick little update just in regards to influenza. If you've all got a copy of the immunisation handbook, that's really great. It kind of needs to go in the bin now because it's really, really out of date. We're going to have to just get used to using the online version. So please make sure that you've got the online version saved to your desktop or your favourites column, whatever it is that you need, and that's the one to be accessing. The influenza chapter has been updated as recently as the 6th of March this year. So with flu season upon us, we just need to make sure that we are using the latest recommendations. ATAGI, the Australian Technical Advisory Group on Immunisation, have released their 2017 vaccine advice for providers. So it is available on the Immunise Australia website. So if you haven't downloaded that yet or haven't seen it, please go ahead and download. John highlighted a little bit earlier in regards to the fact that we will be using the quadrivalent vaccine in Australia this year. Australia will only receive quadrivalent vaccines. So there won't be the confusion there was last year in regards to having a trivalent as well as a quadrivalent vaccine on the market. In your handbook, however, you will still see that trivalent vaccines are still listed there. And that's fine. It just is meaning that they are still registered in Australia. It's just that we won't have any trivalent brought into the country. We have, for the last number of years, since 2010 essentially, had the A strain H1N1 California 2009, which was the pandemic strain. That has been changed out this year to a H1N1 Michigan 2015 strain. But otherwise, that is the only strain change that we are seeing in the quadrivalent vaccine this year. So there is the two strains, the hard to grow and more virulent H3 strain, as well as the two B lineages. So these are the brands of vaccines that you will see coming into both the private market and the national program. I have been advised today that you should have already started receiving, or very soon to receive, the adult formula vaccines. So your Flu Quadri, your Fluarix Tetra and your Afluria Quad for the National Immunisation Program, so the funded program. Flu Quadri Junior has just today, or just this evening actually, I've had an email from Sanofi to say that that has just been cleared by TGA. So there should be stock of Flu Quadri Junior coming through the system over the next few days, which is good news. Just be mindful that if you are receiving your adult formula vaccines into your fridge for the national program, that none of them can be given to children less than 3 years of age. So for those little children 6 months to 3 years that require the 0.25 ml pediatric dose, you are actually going to have to wait until Flu Quadri Junior is available to us. Just some quick screenshots here. This is what your Afluria Quad is going to be looking like. Note that it is registered for use in individuals 18 years of age and over. It will be available on the funded program as well as the private market. As with any of our vaccines, please make sure that they are the colour that they are supposed to be. This one's a slightly opaque liquid, but just make sure there is no real sediment that doesn't go away on shaking. So please make sure that you do shake all of your vaccines. We are very aware that a Afluria Quad is not yet on Medical Director, but I did speak with the Securus people, and as of the 1st of April, it should be. So you may need to just do another update of your medical software after the 1st of April. So make sure that all of your vaccines are protected from light, and of course that storage of 2 to 8 degrees is really important because there's not any really good data about flu vaccine stability outside of the 2 to 8. If you are ordering a Afluria Quad from Securus, you are able to order resources. Your Fluarix Tetra vaccine is a Luoloc syringe. It does come with a separate 23 gauge 25 millimeter needle, which is our normal intramuscular injecting needle. Hopefully you noticed on the Afluria Quad, it is an attached needle that is a 16 millimeter long needle, so a shorter needle, and it is a 25 gauge needle. So please give your vaccine a lot slower because the needle bore is a lot narrower, and the vaccine will be going under more force, which means it could be more painful. So just inject really slowly if you're using a needle with a smaller bore. So Influenza Tetra is our standard vaccinating needle for intramuscular use, which is good. Just a twist on action. Obviously, intramuscular is preferred, but certainly can be given deep subcutaneous. But with this particular needle, there shouldn't be any problem getting into the muscle layer. You can also order Fluorix Tetra resources. There is a health professional login page on the GSK website. Lynn Hughes is our GSK rep here in South Australia, for South Australia. So her details are there, and you, like John said earlier, you will get a copy of this presentation with those details in it. With your Flu Quadri, you've got an adult formula, and then you've got your Flu Quadri Junior, which has a pink band at the top of the packaging. Really important that when we get vaccine out of the fridge and we're doing that very first vaccine check, it is that we have the right vaccine for the right individual. The Flu Quadri Junior does have a pink plunger, so there's another flag for you to understand that you do have the right vaccine for the right person. It is a 25 gauge, 25 millimetre needle, so smaller bore, but same length as our 23 gauge, 25 millimetre needles. Monica Jones is our Sanofi rep here in South Australia, so there are support materials also available for from the Sanofi sites. So just contact Monica if you're wanting anything. You've all seen the funded flu program schedule that's come out from SA Health. If you haven't got a copy of it so far, please let SA Health know. You will also just see in that small little table there that any of the children under 9 years of age that are receiving influenza vaccine for the first time this year, it is recommended they have the 2 doses 4 weeks apart, just to prime their immune system. Please continue to watch your vaccine ordering notice board. They will update that quite frequently, and this was an older snapshot of that screen, but they are sort of now talking about flu vaccines and the fact that you'll be getting adult formula vaccines, but Flu Quadri Junior is yet still to make your fridges. So you've also started ordering your flu vaccines, so we can skip over that. Just be aware of those precautions and adverse events following flu vaccines. Not much different this year, but clearly if people have a previous anaphylaxis to a flu vaccine or a component of the flu vaccine, it is a fully contraindication. Flu vaccines can impair the metabolism of some medications, such as your warfarins and your theophylline. So if you've got patients that are on those medications, you may need to monitor them just a little bit closer. John did talk about GBS, so I won't go into that again. Of course, we're all aware that if people have had GBS, Guillain-Barré syndrome, once in their lifetime, they're at certainly risk of a recurrence of GBS at some stage again within their lifetime. But it is not a contraindication to offering them an influenza vaccine. Egg allergy, we did answer this in the chat box. So egg anaphylaxis, patients can safely be immunised with an influenza vaccine. However, it is recommended that that happens in a supported medical environment. So technically an emergency department or a hospital where people can be admitted for further observation, and obviously a crash cart handy. But if someone's just got a sensitivity to eggs, you can safely vaccinate them in general practice. So otherwise, it's just those common side effects that can actually happen. In regards to, I'm just seeing a chat come into the box here, in regards to the different brands, it really doesn't matter which brand you are offering the adults. They will all do exactly the same thing. They've all got the same protection against every strain. Just the caution that we need to look at is that Afluria Quad being licensed only for adults above 18. So it doesn't matter which one you administer really. But just be really transparent, I suppose, with patients that you are vaccinating against flu. Like John said, vaccine efficacy is pretty low with flu vaccines, and we need to really be transparent about that. We don't want people walking away thinking, oh, well, I've had my flu vaccine this year, I won't get the flu, because the likelihood is that they may well get the flu. It's just that the vaccine antibodies are going to potentially stop them from becoming severely unwell and developing complications needing hospitalisation and potentially even dying. So just remember those basics, that just be professional.
Sorry to interrupt, Angela. Very quickly, we've just had a question come through from Alexandra. She's just wanted to know how long we monitor
I'm
while
sorry, what
foreign
was the
uptake.
question?
We've had a question come through. Alexandra would like to ask, how long do we
For
monitor for
warfarin
warfarin
uptake.
uptake?
That will really depend on the stability of the patient and what their INRs have been. So it's just a caution. A lot of GPs probably wouldn't even bother following up their patients, but the recommendation is that you just may need to monitor them specifically, within the first 2 weeks of receiving the vaccine. So just hopefully that answered your question okay. Obviously, just all of your basics, your anaphylaxis kit, your cold chain, etc., and just remembering those 3 vaccine checks, once getting it out of the fridge, once when you're undoing it from the packaging, and obviously just prior to your administration. Your post-vaccination advice and just that obvious observation, tell people why you want them waiting around for 15 minutes is a really good idea. You're more likely to get them to stay around if you just let them know, we just need you to stay. Monitor for any signs of feeling unwell. If you feel unwell, somebody will come and get me straight away or come back in. And certainly the not driving for 30 minutes is really important because of the risk of vasovagals. And certainly reporting all of your adverse events is really important. Quick overview of flu. So now pneumococcal vaccines, John's talked about the conjugate, which is your Prevnar 13, and your polysaccharide vaccine, which is your Pneumovax 23. Here's where your Prevnar 13, your conjugate vaccine, sits on the schedule, because clearly polysaccharide vaccines are not overly effective in children less than 2, and yet the highest rates of pneumococcal disease is in children under 2. So in order to protect these children, they've conjugated the vaccine, and therefore we can be giving them a vaccine early in their lifetime. Just be aware of that 4th dose of Prevnar 13 is offered to Aboriginal children at 12 months of age, and also to children with specific chronic medical conditions. So definitely ask the question, do you identify as Aboriginal or Torres Strait Islander? And it's just that importance of doing that pre-vaccination checklist before you vaccinate. Individuals over the age of 5 with Prevnar 13, if they have a Category A condition and they are Prevnar 13 naive, then they are required to have a single dose of Prevnar 13 if they have a Category A medical condition, but unfortunately it is not funded and it is not PBS listed. Your Pneumovax 23 is recommended for children with chronic medical conditions at 4 years of age, so those little ones that you've already given a booster at 12 months will have, with your Prevnar 13, will have a Pneumovax 23 at 4 years of age. Once again, important to do that pre-vaccination checklist. And of course, Pneumovax 23 is on the NIP for older Australians. If someone has a Category B medical condition, then there is recommendation for them to have additional doses of Pneumovax 23, and we will go through that very, very shortly. If anybody has tried to navigate the pneumococcal chapter in the handbook, if anybody has succeeded in navigating that chapter, then you are all on your own, because this is exceptionally complex. And I think John has highlighted how complex influenza disease is, and definitely how complex pneumococcal disease is. So the vaccine pathways are also exceptionally complex. And whilst we are still waiting to see what PBAC actually does in regards to these complex pathways, it may well be simplified if they do bring on Prevnar 13, but we're yet to wait and see. Just in discussion, even if PBAC do go forward and it is recommended to change, we may need to be waiting 12 to 18 months for that change to actually be implemented. So it's still worthwhile proceeding and showing you this particular tool. So just bear with me. I need to do some little tweaks here on my screen so you can actually see what I'm going to be showing you. So just bear with me. Okay, so can everybody see an immunisation coalition page? I hope so. Alex or John, would you, and Luke, would you be able to tell me if that is not happening? Thank you. Okay, so it's all good?
Yes, we can.
Okay, so this is the Pneumasmart vaccination tool. I'll quickly run through it just so you can see that you need to tick that you've read the terms and conditions, but just like everything else, you potentially haven't, but let me say that you have. I'm just going to give away my age here just because it's too hard to think of somebody else. Then going to ask me, am I Indigenous? I'm going to say, obviously I am not. It's going to default to my age category based on the date of birth that I've put in. I'm going to ask, do I have a category A medical condition? So I'm going to perhaps suggest that yes, I've got a malignancy, a hematological or other malignancy. If I scroll down, it's going to just tick OK. It's then going to ask me, do I have a chronic medical condition from the category B column? It doesn't really matter. If you've already ticked something in category A, the tool will take you to the category A pathway. So it doesn't really matter, but it's there for us anyway. And I'm going to say that I have got diabetes. I'll click OK. It's going to ask, have you had previous pneumococcal vaccine since you were 5 years of age? Now, most of the clients are going to say, well, I've got absolutely no idea. And that's fine because it will take you to a really simple pathway of what you should be given. But if I was to tick yes, it's going to ask me, was it the Prevnar 13 or was it a Pneumovax 23 or was it one of each, or have I got no clue? So if you've got a vaccine record in front of you, then, and I can see that yes, it was a polysaccharide vaccine that I have been given previously, it will then take you to the review summary. So it will tell you who your patient is, whether they're Aboriginal or not, with what medical conditions they've got, and then it's going to tell you they're Aboriginal or not, with what medical conditions they've got, and then it's going to tell you what vaccine you should be giving now and what vaccines you should be giving in the future, observing those minimum intervals, and then is it funded, PVS listed, or is it actually an NIP vaccine? And you will see here that that first table, if the patient had received that Pneumovax 23 after 5 years of age but before 18 years of age, it is considered a dose in childhood. With Pneumovax 23, it's recommended that people do not receive more than 3 doses in their adult lifetime. So clearly, with that second table that's on the page, if the patient received the Pneumovax 23 after 18 years of age, it's considered the first adult dose, and therefore the table actually does change. So you can then print this out, scan it, pop it into the client's records. The other thing that I will actually show you is if, for example, I have got, let's put myself in here again. And I'm not one of those, and I'm okay with that. If my medical condition was actually a hematopoietic stem cell transplant, if I was to tick that and go, okay, it's not even going to ask me about the category B medical conditions because it's totally irrelevant. So the reason being that with hematopoietic stem cell transplants, it is a complete schedule all to itself, irrespective of what vaccines an individual has had previously. There is, I'll just go back now to my slides. So hopefully we're back to the slides again. There is a Pneumosmart vaccination tool that is available if you were to Google it, but it is the old version of this tool. So yes, it will still work, but it's a bit clunky. So when you receive a copy of this presentation, please make sure that you access the tool using this particular web link, if you like. Okay. All right, so we'll just, other programs updates, just remember Bexsero trickling into the country if people are demanding it, and also the B part of it, meningococcal B study here in the school program this year. We've got a fact sheet on the Adelaide PHN website, so please download that if you need it. Zostavax supply will still be limited, possibly for the next couple of months, but then we should be having more supply around. Some of the states are already increasing the numbers that they are sending to providers. So just vaccinate at 28, that very, very important pertussis vaccine booster. For those of you in the country region, there is a meningococcal W program happening around the Ceduna region, but it is very, very specific to Ceduna region. So just make sure we recap. We're just going to be making sure we offer the vaccines, like John said. What health professionals say to their patients is really taken on board, and these patients will not receive these vaccines, ideally, if they are not recommended by you or the GP. Certainly do that pre-vaccination checklist. If it's not safe to vaccinate, don't vaccinate. If something's not safe to do, just don't do it. Make sure you just follow all of your processes and also do all that documentation, and particularly to the AIR and particularly to a handheld record that they can take home. There are problems transmitting adult immunisation data to the AIR. We're very aware of that. But it's so important, these significant vaccines such as your pneumococcal vaccines and your Zostavax are actually being recorded on the AIR. So just use the Pneumosmart tool. I'd love to get some feedback from you. We will be doing a little bit of a study and recruiting some practices to help us with that study. So we may be in touch with you. We are here to help you. Immunisation Hub consists of Alex, who's online helping answer the questions, and myself, and also Tracy Maynard for the country region. We've got a couple of champion immunisation nurses on the ground here in metropolitan Adelaide at the moment that can go out to practices and assist mentoring nurses that are new to immunisation. They're doing a lot of work in the pharmacy sector and just helping the pharmacists out in regards to how they're going with their first lot of vaccines. And of course, you've always got SA Health, the girls in there, to give you a hand as well. But I just last minute comment, and I know we're just a few minutes over time. you are doing an absolutely sensational job out there, and the work that you are doing on the ground in practices is not easy work, but by golly, it makes my job so much easier. And I just think you're absolutely amazing, and just so appreciate everything that you're doing. We're here to help you. You're certainly helping us. So contact us whenever you think that you want to have a chat or get any information to us. Bear in mind that we do have the immunisation provider network here in South Australia. It's over 280 members strong now. We send out lots of immunisation information, so please jump onto that SurveyMonkey link and register and become a member. Also, the NCIRS, the National Centre for Immunisation Research and Surveillance, also have a network for Australian Immunisation Professionals Network. This is a fabulous network where you can email them a question, watch the discussion. An expert will get back to you and answer your question for you in less than 48 hours. So absolutely great to join that particular network. So that is the end of my presentation as well. So I am not sure if there are any additional
And Angela, while people are thinking of their
that anybody
questions,
is wishing to ask.
we need to congratulate everybody about what a good job they've done with Zostavax. While we don't have coverage data yet, and probably won't until the end of the year, we are aware that we've actually exceeded the Seqirus' expectations significantly in terms of rolling out doses. And what I can say is that we will have coverage levels of Zostavax after 12 months that the POMs only managed to get after 3 years. So we've done a really good job. We've doubled the rollout of that, despite the fact that the vaccine's been in short supply. So everybody give themselves a pat on the back. I'm hoping that we're actually going to have Zostavax coverage levels that will beat flu and pneumo when we finally get the data. But well done.
Yeah, it's fantastic, and there's a lot of chat around putting things onto the AIR. We are certainly wanting providers to do that, and we know that time is a big factor for you. But we've just got to keep our fingers crossed that the medical software people, do their bit here and actually have the software transferring the data for you, and the Commonwealth and the PHNs, we're all working with.
So are there any final
and
questions on
trying
anything?
to push them forward. So just
Final
one last
questions on
comment
anything?
there. One last comment. Where do we go for good info for post-vaccination info for patients? If it's just for flu immunisation, then certainly those resources that the vaccine companies are giving out will have that. But otherwise, the vaccine tear-off leaflet that SA Health has also addresses the adverse events that are generic to all vaccines, but also the specific side effects for the specific vaccines. So you could always be using those as well. So I hope you've enjoyed the webinar. I would just like to acknowledge that the webinar was sponsored by Seqirus tonight, and their help has been absolutely amazing for us to be able to get around the state and educate as many people as we possibly can. So it's absolutely fantastic. So thank you very much all for joining in, and you are now free to go if you would like to. Unless you've got more questions, we're happy to hang around. Thanks so much. Bye.
Thanks for your presentation, John and Angela, and thank you to everyone for attending tonight. We'll wait a few minutes for a few more questions.
Thank you for your assistance too, Luke. It's been fantastic.
Yes, I'm not quite sure why the slide lag was there. We haven't worked that one out. So, Alex, if you could have a look into it. 'Cause the only thing that happened at my end was my mouse stopped working on the advanced, and I had to use the on-screen one. And I don't know if it was having a lag problem from the start, but worth having a look at.